All right, welcome everybody to the Incarceration Prevention and Reduction Task Force and Law and Justice Council meeting for May 13th, 2024. We have a good agenda today, and as always, I'd like to start with the land acknowledgement. I'm Peter Frazier. I'm a new co-chair with Heather, and Heather Flaherty and I have, I guess we're about 2 months in to our co-chairpersonship and working closely with Bertie Safford, Dr. Bertie Safford, a fairly new member of the IPRTF, and I'm always available to any of you, very interested in what you're thinking about and the work of the IPR. So feel free to reach out to me at any time. So before we begin, we acknowledge that we are gathered on the traditional and unceded territory of the Lummi, Nooksack, Samish, and Semiahmoo people who have cared for and tended this land since time immemorial. Truth and acknowledgement are critical to building mutual respect and connection across all barriers of heritage and difference. We begin this effort to acknowledge what has been buried by honoring the truth. We pay respect to their elders, past and present. Please take a moment to consider the many legacies of violence, displacement, migration, and settlement that bring us together here today. And please join us in uncovering such truths at any and all public events. I myself was on Chuckanut Island, where I'm the steward for the Nature Conservancy for the island, and was looking at the middens and thinking myself about our long heritage of our neighbors from the Lummi Nooksack tribes. All right, let's see. My agenda is covered, has disappeared, but I think I can get going anyway. So our first agenda item is we're really pleased to have Jan Rose Ottaway Martin, who is the Executive Director of the North Sound Behavioral Health Administrative Services Organization, our regional partners. And I am very interested in hearing her presentation. I am shuffling our agenda so that we can have as much time as possible. I'm hoping we have even as much as an hour for this section, and I'm sure we all have questions for her. So let's begin there. And Ms. Ottaway Martin, would you take it away?
Sure. I have a brief PowerPoint that I'll bring up in a second, but just to introduce myself, for those who may be less aware of our organization, I actually started in this position in September of this last year, so 2023. I replaced, though replace is not a fair term, I think, the illustrious Joe Valentine, who was the previous executive director. He did an amazing job with North Sound BHASO, and I'm honored and privileged to kind of take up that mantle from his position before. A little bit about myself. So while I started here in September of this last year, I am no stranger to administrating behavioral health services. I was at King County Behavioral Health and Recovery Division from 2016 till 2023, where I held multiple positions, building essentially their King County Integrated Care Network, which is the Medicaid body of outpatient services. And I'm saying that very quickly with a very deep understanding that I'm going to throw out a lot of stuff. At any time as I'm talking, if there's any questions, please know I'm fine being interrupted. I'm fine people raising their hand. Just I know that behavioral health can be kind of a complicated world. Prior to that, I was actually an outpatient supervisor and clinician for Downtown Emergency Services Center. So as a clinician, I specialized in those that are unhoused who experienced acute co-occurring disorders between behavioral health and substance use addiction issues. So kind of a long history in behavioral health in general. With that, I'm going to do that lovely shuffle we all know, which is trying to share a PowerPoint in a Zoom meeting. Can you guys see a PowerPoint?
Yes, we can. Thank you.
Perfect. I'll go ahead and get started. As some background too, I was actually raised in the North Sound area. I was raised in Snohomish County. My bachelor's degree is from Western Washington University, so I have a pretty long history with Whatcom County as well. And I'm excited to work in the region I actually live. Probably for the first time in my career, most of my work had actually been done in King County prior to this. So I'm here to talk to you today about the Behavioral Health Administrative Services Organization. We call it North Sound ASO or North Sound BHASO for short. None of those necessarily feel short, but we'll just say that it feels shorter than our total title. On this page, and I'm happy to share this PowerPoint after today's meeting, I also have a WAC reference. So in 2018, during a period of a couple years, the state did what they call integration. So integration is the merging of managed care organizations or insurance companies in the management of behavioral health care. During that time, there was a transition for entities such as my own. We shifted roles. We used to manage the entire Medicaid and non-Medicaid portion of behavioral health, and now we have a much smaller portion of the continuum. But the WAC that guides us is 7124045. So that is the WAC that set up BHASOs in our state, which are the regional bodies that oversee the behavioral health crisis continuum of care, not to be mistaken by the entire continuum of care. So I may not be able to see hands as they raise, so please speak out. In order to see the total slide, I have to kind of minimize that particular window. So feel free to speak out as I go through this if there's any questions. When we talk about the behavioral health service continuum, that is a wide range of services. That's everything from prevention, outpatient substance use disorder and mental health treatment, detox services, medication for opioid use disorders or MOUD, that's your methadones, your buprenorphine, those types of meds, residential substance use disorder and mental health treatment, crisis services, evaluation and treatment. For that one, we're really speaking to the designated crisis responders who do evaluations for the Involuntary Treatment Act, and then hospitalization at the furthest side of the continuum, which includes evaluation and treatment facilities, local hospitals, and then also our larger state hospitals like Western State. In that continuum of care, post-integration in about 2018, Norsound actually only manages a certain amount of this body of work. So if you see, can you guys see my mouse when I'm moving it?
Yes. Yes,
Okay,
we can.
perfect. So if you look from prevention all the way to this end, this residential substance use disorder mental health, on the Medicaid side of the population, which is the much larger portion of the population, the managed care organizations control all payment, contracting, and requirements for those services. So the ASO does not control that body of work anymore. Prior to integration, we did, so we had a little bit more, a lot more control over those bodies of work. But now all of that sits with the 5 managed care organizations that work in the state of Washington. And each region has a certain number of insurance companies. Our region has all 5 represented. On the ASO side, you'll see that I have down here non-Medicaid. So for that same continuum of care, we do actually touch it just at a much smaller level. We provide services for those who don't qualify for Medicaid, but still meet federal poverty line numbers. So historically, this has included a fair amount of people who are immigrants to our country who maybe for various reasons don't qualify for Medicaid yet. It also can include people who don't currently qualify for Medicaid because financially they're just slightly above where the Medicaid line is, but they still fall under the 225% of the poverty line, which allows us to serve them. The priority being, of course, that if we can help serve people on behavioral health, then hopefully we can help stabilize the rest of the bodies of their life as well. So those funds flow through the ASO. What we do manage entirely is this side from crisis to hospital, and entirely kind of varies by the body of work I'm talking about. We hold the contracts, for example, for the mobile crisis teams in Whatcom County, the designated crisis responders. We pay for hospital stays that are related to behavioral health, though we don't audit those stays. We don't have that level of power over that body of work. And also on that side of the body of the continuum, we also pay for the court costs associated with ITA court, but obviously we don't supervise prosecuting attorneys or public defenders. We're a flow through for the cash on that side of the business. So under the BHASO, here's a list of programs that are examples. This is not exhaustive, and towards the end of my presentation, I actually have a link that people can go into and you could see a much wider representation of all the services we provide. But some include designated crisis responders. So again, those people who are doing ITA evaluations for individuals who maybe need hospitalization due to being a danger to themselves, others, or grave disability. HOST, which is an outreach program that exists in Snohomish and soon to be Skagit in Island County. That's an outreach program that was designed in King County originally to work with the unhoused population that brings a really low bar to engaging people in outreach programs to then hopefully work with them to build trust and expand to potentially getting enrolled in Medicaid and seeking additional behavioral health services. Mobile crisis outreach teams, which can come out for calls prior to designated crisis responders needing to respond, or maybe when that urgency looks a little different. The regional crisis line, so that's currently managed by us and the contract is held by Volunteers of America. That is shifting and merging with the body of work on 988 coordination. 988, for those who are unaware, is the new phone line that will be like 911, but for behavioral health crises, and is the number people would be able to call in the future to seek behavioral health assistance in any form, from the lowest version of that, which might be a basic conversation, to I need someone to come out and assess someone because they're in crisis. Community Behavioral Health Rental Assistance Program. This is a federal program, CBRA, that helps cover rental assistance for people who meet certain parameters of behavioral health issues. The dedicated cannabis account, these are the tax funds that flow through legalization of cannabis in our state. They are tied very specifically to programs that have to educate around cannabis in particular. So it's kind of limited in the scopes of what it can cover, but we manage those funds in our region. We also provide currently financial support to co-responder programs throughout the region, as well as are exploring additional ways to funnel more funds into the co-responder programs. North Sound region has actually adopted through all 5 of our counties very robust co-responder programs, which have been really effective in the communities. And we are looking for any way we can help support that in our region. Our region, by the way, I think I did not mention at this beginning, just so that people know, we cover Snohomish, Skagit, Whatcom, Island, and San Juan counties. That's the total North Sound region. Assisted outpatient treatment. This is a court diversion program for people who are experiencing significant and acute behavioral health issues. Recovery navigator programs. We also manage all federal block grant programs in our region, including specialty programs like opioid outreach, programs for pregnant and parenting women, et cetera. So kind of a large body that are fit under that parameter. We do regional coordination across multiple pieces. So that can be everything from pulling together all the providers to have regional problem solving, legislative priorities, conversations around how the crisis system and honestly the entire behavioral health continuum is doing, to more specific problem solving groups, such as if there was a frustration with a required program like designated crisis responders, we pull together the people in the community to try to say, how do we fix this? How do we correct it? Because at the end of the day, we're public servants, much like county employees. So our requirement is to serve the community we are in and to meet the needs of the community. And so whatever regional coordination that looks like, we are willing to be a partner in and or the facilitator of, which leads to that last item. We are the holders of the North Sound Opioid Abatement Council. This is the Opioid Abatement Council that's tied to the opioid settlement dollars that are in Washington State under the One Washington Agreement. So it requires that each region that are getting these funds also maintains a opioid abatement council, which I'm happy to talk more about. But we facilitate the one for our region and pull together all the partners from all the counties and the participating cities to make that operational in our region. Highlighting kind of upcoming
Could I ask a
projects.
question?
Oh, of course.
Um, is your work, do you touch the privately insured population at all, or do you have any coordination with them? Or is it all Medicaid and other, and then the non-Medicaid eligible people below poverty level?
That is a great question, and it's kind of ever changing. So historically, when we go back to this continuum that you see in front of you, historically, Washington State has actually covered the crisis behavioral health system for privately insured people. What that means is that in establishing a firehouse model for crisis services in Washington State for behavioral health in particular, the private insurance companies were never billed for that. 2 or 3 years ago, legislation passed, it was called 1688, where the legislator said, that's not how this should be. We should not cover for the private insurance companies. What's been happening since then is trying to understand who and where we bill for the private insurance companies and the clients who access this level. So historically, no, we've not touched those other than we covered those people. We were just blind to whether they were in our system. But moving forward, actually, we are in the process of setting up direct contracts with the private insurance companies because of that legislation and having it in place that we are getting payment from the private insurance companies for this body of work. Does that answer your question or?
Yeah, that's great. Thank you very much.
Perfect. Were there any other questions
Actually,
on?
Jan, this is Mike. Thanks for your presentation so far. It seemed like when you went down this particular slide that you're on, and thank you for going back here, there was pretty good coverage in the service area, but you mentioned the host outreach program and Wacom was not included in that. I'm just wondering if you could touch on that for us.
Yeah, so host program started, it was actually at DESE, my previous agency started the host program. I want to say 15 years ago. It's been long running in King County at this point, but it was only recently that the state really started putting funds into establishing host programs throughout the state. And the way that they've been doing it is that they've been doing specific focus on substance use disorder specific host. The original host program as it existed in Seattle and still exists in Seattle, it touches anyone who's unhoused or kind of meets that acute presentation specifically from mental health. And if they have co-occurring disorders, that's treated as well. It's not the primary. But the state has been focused on substance use disorder host and putting money into setting up those teams. Those teams can be very costly to set up. So it's been a kind of a slow process expanding throughout the state. In our region, the first team was actually established in Snohomish County first. Evergreen Recovery manages that program. One of the issues in our region that I think we run into, not just on the outpatient side, but in the crisis continuum, is sometimes a lack of behavioral health agencies who have the ability to step into these new programs. So while they were piloting host here in Snohomish County, that agency recently came to us and said, we would be willing to expand into Skagit and Island County next. And we have the funds right now to support that kind of expansion. I think our hope would be as they get their feet under them, then we can also look at, is this a program we can expand into Whatcom County? But we're somewhat hands are tied in some ways by the agencies that are willing to do those bodies of work. And we just so happen to have one in our region that's expanding in a way that we can help meet that need. But the state hasn't put a lot of new funds to starting these teams up in the last year. And I don't think that they're foreseen to do so in the near future. So we're hoping we can establish these in Whatcom County soon, but we don't know when that might be able to happen. Part of the reason too that they're county specific or regional or smaller community specific is that the host outreach teams really focus on, they might carry a caseload individually of each clinician on the team of as little as 12 because they're highly intense outreach. And in order to maintain that, they have to have really small caseloads. But on their team, they also have a prescriber and crisis people who can respond to those on the host program very quickly. So it can be a very costly intervention.
Sure. No, it makes sense. It also sounds really valuable. So I think that we'll be keenly
Yes.
interested. Could you briefly, it seems like it touches on a couple of areas, and I don't want to take a ton of time, but PACT and like frequent utilizer programs like CHART, or in Whatcom County, we have GRACE. Would you just very quickly maybe thumbnail sketch how host is different from those two?
I don't know that Grace, I'm not as familiar with Grace right now. So I would say that often in outreach programs, there is
Love.
a really, oh, sorry.
I said we need to help you with GRACE
Yes.
authorization. We're a big fan of that program here, but I'm sorry, I didn't mean to interrupt you. Go ahead.
So one of the ways that I've heard hosts described differently is, well, one, the use of a prescriber on the team is pretty significant. When you think of a host client, you are thinking really of the most acute of your people with behavioral health issues. So in my experience of working with host clients, because I worked in partnership with the original host program in Seattle, when the outreach employees start working with those host people, they're often not even introducing themselves as I'm a mental health specialist. Technically, host teams don't always have to have mental health specialists. They lead with a lot of peer specialists in this body of work. And their initial steps are so baby steps that it really is establishing trust at the most basic level. And so when they are meeting with clients, these are the people who takes 2 years before you get their a legal name that you can work with sometimes. Sometimes they're dealing with schizophrenic symptoms so severe that they're speaking in word salad, often very high presence of drug addiction issues. So it's kind of when you look at the whole tier of how behavioral health can present itself in individuals, you're talking about your 1% most difficult cases at the very top. That is the host team's jam. That's who they focus on. And so they take those often extremely high utilizers of the system, very acute symptoms, and they do an intense level of outreach and focus on those people. They don't kind of spread the outreach attempts across a larger population. They put them on caseloads and they work with them for, I think, on average, a year and a half before that person is at a point of stabilization that they can transfer them to ongoing outpatient services. The other outreach programs are extremely valuable as well, but if you looked at a continuum within any kind of region that has host and other outreach programs, you'd often want to do some kind of coordinating work. And this is work we're starting in Skagit and Island County to start pulling off. These are the ones we want hosts to focus on because they need that level of support and the prescriber who's able to work with them. And then the rest kind of get assigned down through the other outreach programs. So you'd isolate and prioritize who goes on a host team.
That's
And
super. Thank you.
and honestly, the agency that started host, you asked about a comparison to PACT. Host doesn't have housing resources. And I would say that the population you would generally see enrolled in a PACT population may be very similar. They'd probably share a lot of overlap in who they could serve. It's just, again, a prioritization. If you have one program with housing and one that doesn't, there might be certain things you're considering and who gets assigned to PACT and who gets assigned to host.
Thank you for that. Arlene, what's your question?
Yes, I've served for many years on the BHASO before you came into power. And one of the programs that we were able to start was the Navigator Recovery Program, but it was very limited. And so I wonder if you have been able to expand it. There are certain people who benefit tremendously from having someone follow them all the way to recovery and more. And so, have you done that?
Yes, so the recovery, and I cannot claim credit for it, having started in September, that expansion happened even prior to me starting. Recovery Navigator programs is all 5 counties and pretty robustly hired at this point, so it is operational. And then one of the things on one of my last slides where I talk about upcoming projects, and I can explain more on that last slide, is we're about to start the Youth Recovery Navigator program. So that's kind of the last puzzle piece in the Recovery Navigator programs. But yes, that program in particular can really assist people long-term in having continuous case management to help in their process of recovery. And so yes, we have it. It is throughout our whole region, and we're excited to start the youth version of that shortly.
Thank you.
Tank, you have a question?
Yes, and thank you for being here. So with regard to the Abatement Council and the funding for this region, can you briefly describe some of the uses for that funding and if any of that funding is directed towards law enforcement's use? Thank you.
Yes, in fact, I could bring up a secondary slide deck that I did recently at another group talking about the Opioid Abatement Council and what their role is. So the Opioid Abatement Council, the way that it was set up in our region, this was outlined by the prosecuting attorneys, I think largely Whatcom, Snohomish, and Skagit, but all 5 counties prosecuting attorneys were involved. They did a regional interregional agreement. So the members of the Opioid Abatement Council include 1 representative from each county. And then in the county, let's say Whatcom, the cities over 10,000 people also get a certain percentage of the settlement funds as well. And each county's grouping of cities gets 1 representative. So you would take 1 Whatcom County representative and then 1 representative representing the cities in that county that also are getting funding. There is a list of items that those funds are used for, and I actually can bring it up right after I'm done with this slide deck. I'm happy to share that. Definitely law enforcement work is included in those bodies, and when you go into the One Washington Agreement, I have a more abbreviated summarized list of what the purposes of those funds are or what they can be used for. But the more detailed kind of explanation of each of the items I'll touch on when I get to that slide is in the One Washington Agreement. And then for those who don't know, the One Washington Agreement also includes the formula with which each county and city are getting their funds. So one thing that the Opioid Abatement Council does not have control of in our region is actually funds. So we do not get any of the funds for the opioid settlements. We do not create the spending plans. The way that it's set up in our region is that the counties and the cities over 10,000, which is what the One Washington Agreement outlined, get the funds themselves. And then they create their spending plans to align with what they believe their community needs. Cities also get those funds if they have over 10,000 people, but they also have the option of funneling their funds back to their county of residence if that is what they would prefer. Honestly, the opioid abatement settlement funds, I think people see really large dollars associated with those funds. The unfortunate truth is that when you break that down by all of the counties and cities getting it, and then over 17 years, it's not nearly as much money, I think, each year as people were hoping for. And then we've also struggled with some bankruptcies affecting some of those payouts. But I am happy to bring up the purposes or how those funds are supposed to be used once I get out of this PowerPoint and can get into a different one.
Thank you.
Thank you so much for your question, Sheriff Tanksley. And why don't you head on with your presentation, and we'll take more questions in a bit.
Perfect. So upcoming projects and programs that North Sound is working on right now. So dispatch protocol for 988, this was actually a Senate bill passed this last legislative session, Senate Bill 6251. Essentially, we have our regional crisis lines, and then we have this 988 line that's coming online or is online, but isn't being fully utilized yet. 988 is largely going to be funded by some telecom tax dollars, some pretty significant telecom tax dollars. And because of that, more money is expected to flow into mobile crisis teams, which kind of flows into the item below. Our role at the ASO is going to be working with stakeholders in our region to identify what dispatch protocols look like for 988 and creating dispatch protocols that make sense for our behavioral health programs in our region. And one interesting piece there that I think we don't have control of, but we are looking forward to working with partners on, is that use of co-responders in these dispatch protocols. There's the potential of additional funding for co-responder programs that we were unaware of historically. So figuring out how to make the most robust behavioral health crisis system that we can in our region is definitely a big goal of ours. We also have existing mobile crisis teams, and I acknowledge that I think Whatcom County's team, there is one team to serve all of Whatcom County. But with this new 988 number and the telecom tax dollars that are flowing out of that, we actually are getting an opportunity for more mobile crisis teams through, it's a whole new acronym, but it's MRRCT, Mobile Rapid Response Crisis Teams, and CBCT, which is community-based crisis teams. Now, you don't need to remember any of that, I promise. What it means is we have the ability to potentially see fire departments and EMS also create mobile crisis teams in a new way than that they've historically done in Washington State. So we're in the process, the very beginning process of reaching out to partners who are at fire departments and EMS to try to set up a regional call for information sharing. The state's kind of been flowing this information out like a fire hose, and we want to step back and ensure that those partners in our community are aware of the opportunities that are about to come, and we can speak to how it can benefit our system. Mobile crisis teams currently have a pretty significant requirement for response, but these endorsed standards for mobile crisis teams that are going to be released shortly, they're currently in draft format for WACs, could require crisis teams to leave their office or wherever they are and respond to crisis within less than an hour, which is, I think if I have anyone, it sounds like I have law enforcement on this call, that would be a pretty big change in getting mobile crisis out on site very quickly. So maybe a lot coming down the pipeline on mobile crisis teams in general. The Youth Navigator program, so we had the Recovery Navigator program on our last slide. We are one of two regions that are the last to go live with the Youth Navigator program. Now, the idea of this program, it has very specific requirements about assisting with hospitalization and other issues kind of in the youth population, but how it's rolled out in the rest of Washington State is that the positions that are funded by this particular HCA contract has allowed for more active problem solving with families and youth in our community. And I can tell you that I receive phone calls from families, I receive phone calls from friends of my own who are trying to navigate behavioral health systems for their youth, children under the age of 18, and how much of a struggle that is and how much they feel unsupported as they're trying to avoid youth going into crisis and having more significant long-lasting issues. So we are bringing this online. These positions will be under the BHASO. We had the opportunity to either contract it out or maintain it in-house. We're going to keep it in-house, and the reason for that is because it is supposed to serve the entire region. We want to keep a close eye on this program and be able to be reactive if the community has needs that we can incorporate into it and ensure that we're meeting the family and youth needs in our region via this program. It will have 3 positions for our whole region, which doesn't sound like a lot, but I've seen it be very impactful in the rest of the state. So I'm hopeful that we will see the same here. Assisted outpatient treatment pilot. This is a pilot currently in Snohomish County. It requires a significant amount of time of public defenders, prosecuting attorneys' offices, and court to set up an assisted outpatient treatment, as well as having behavioral health agencies that are able to provide the services associated with this program. For this program in our pilot in Snohomish County, we are contracted with Concur, which is a relatively new agency in our region. But the idea would be that people are identified to go through this program, and there's a lot of different referral sources. I believe that we are currently staging out which referral sources will be able to access and put referrals into this program. But essentially, this diversion program is being modeled after originally an Ohio program where clients who are experiencing an acuity of behavioral health symptoms and issues who end up being often kind of our frequent faces in most of our services, a person could put a referral in and they could go through potentially this pathway instead of hospitalization that would require them to engage in outpatient services. There are some stumbling blocks on this. This is why we're definitely testing in one county first before exploring how it would be expanded to other counties. The state that originally designed this program has different patient rights than we have in Washington state, and how that interacts with this program is something we have to figure out before we can expand it to a larger audience. Either way, it would require courts, prosecuting attorneys, and public defenders to have the bandwidth to do it, which I think is the other fear right now. And I'll talk about that in a minute. We are also currently in the process of strategic planning. When 5 years ago integration happened in our region, the BHASO had to really work hard to figure out how to navigate even just kind of continuing to exist, what it looks like to be a BHASO in our region. We're now 5+ years post-integration and a whole pandemic on the other side. I think we are at a point right now where we really want to explore how does the ASO not just meet healthcare authority requirements or our contractors' requirements, but expand to what this region needs to meet the needs of behavioral health crisis services. And so we are starting with our board of directors in June. We have a board of directors retreat, and then we'll be expanding it to larger tables and getting community input into where the ASO should go. What does it mean to serve our community and behavioral health crisis continuum? I've been in behavioral health for a very long time now, and there's not been a single point of my work in behavioral health where behavioral health hasn't been presented as being in crisis, right? It's a continuous being in crisis and not having enough providers and services to meet the needs of our community. And that gap feels ever increasing. So I want to make sure that the ASO is more intrinsically locked in with the community to ensure that we're actually expanding to what the community needs and not being kind of afraid to look in different directions than maybe we historically have looked.
I see that there's an open,
Okay.
may I ask a question?
Of
I
course.
see that there's an opening on your advisory board for Whatcom County. And I was wondering if, I just wanted to make sure everybody was aware of that. And I would presume that they are part of your strategic planning process and would encourage us to have a good full advisory committee for you.
Yes, and what I would tell you is I think I have been at many entities where advisory boards maybe weren't as robust or partners in the work that is happening at an agency. The advisory board at North Sound is 100% aligned and working with us on the issues that we're talking about. So strategic planning will absolutely go to them as well. They are also one of our first sounding boards when we're rolling out new programs to get their questions to ensure that we're thinking about things that we hadn't thought about before. They are also currently, of their own volition, this wasn't an ask to them, they had decided to move forward with scheduling and planning a legislative forum for North Sound BHASO, which is amazing. I think the fact that they want to own it and that they're really interested in ensuring that legislative priorities for our region are really well heard. And of course, they're partnering with me and my leadership team, but I highly recommend if you've considered being a member of an advisory board before, this would be a really good one if you have any interest in behavioral health, because they are a very active and proactive advisory board.
Well, the money comes through their hands, so it's very important for that reason too.
Are you referring to the motions going through advisory board or contract amendments?
Well, most of the money that entities receive comes through the board because we approved it every year.
Yeah, so you're referring, one of the things our advisory board does that I can tell you no other advisory board for an ASO does in the state is we manage our contracts in a very transparent way with our agencies. So when we are doing amendments to contracts or updating them, all of those amendments and contracts flow through our advisory board and our board of directors, which is actually not standard practice through the rest of the state, but it definitely establishes a level of transparency and healthy questioning in our body of work to ensure that we're doing what we are meant to be doing and providing at the end of the day the services to the clients in our region in the way that we should. So yeah, I think that that is another great call out.
Okay, thank you.
On the next item on here, we've been working with some partners in our region around problem solving Involuntary Treatment Act court issues. Seattle Times has run a couple of articles recently in the last few months. We actually expect this to be a potentially pretty major issue on next legislative session. But between workforce shortages at prosecuting attorneys' offices, workforce shortages at public defenders, there's been a question in many courts throughout Washington state about capacity to actually have ITA cases or how those ITA cases flow through. So these are people who were picked up by designated crisis responders because they are identified as being an imminent threat to themselves, others, or of grave disability to the point of hospitalization. And once they are picked up within 120 hours, they have to have an ITA court case. Basically, a court is involved in ensuring that their rights have been protected as they go through this situation. But the workforce shortages that we've experienced across behavioral health is also very much experienced in our criminal justice system and has led to some pretty significant conversations about what it means to continue to support the court systems and specifically ITA in this case. So not a lot of answers yet on that front. I know the public defenders were able to work with their governing entities to establish smaller caseloads to make it more doable to do that body of work. We don't know the full impacts kind of as we move along, but this is something we definitely have our eye on and are working with the state and other partners on how to manage moving forward. I am also about to start representing ASOs at a new jail modernization task force. This is brand new from my understanding via proviso that will put forward recommendations by the end of the year. And I'm going to try to bring up, I have a secondary document that I was going to refer to let you guys know what that group is going to be focused on. You guys still see the PowerPoint, right?
Yes, we do.
Perfect. I shared it correctly. That's great. So the jail modernization task force has been charged by proviso to put forward recommendations around the following items. So employee retention issues and potential solutions, the impact of overtime, jail atmosphere, emergency response time, and inexperienced corrections officers and how to overcome these challenges, the type of facility needed to house those with behavioral health needs and associated costs of these facilities, available diversion programs and their costs, types of existing behavioral health facilities for those involved in the criminal justice system, the cost of building and running these facilities, how these facilities vary by location, the viability of offering facilities in every county, and potential system improvements to the types of services and supports offered and delivered to those with behavioral health needs. The types of services and supports provided to those exiting the jail system, what reforms are necessary to create and enhance a seamless transition back to the community following jail confinement. This whole body of work is the meetings are supposed to start in December of this year, though they're doing some work prior to that. And then the idea is that recommendations would be ready for legislators as early as the end of 2025. And I bring this up specifically in this work group and for Whatcom County, knowing that you guys are doing a lot of work with your new jail levy. And so my hope is that there will be a partnership. I will be attending this task force. I'm not sure who else will, but that I am getting direct feedback in that I can flow into the task force to have some of these conversations at the state level.
That's great. I'll be very interested in hearing about that work and coordinating in whatever way.
Mm-hmm. Yeah, and I'm hopeful. I think they're going to try to start. It's being overseen by the Ruckle House Center, which is a partnership between Wazoo and UW. They have a center that actually does kind of policy facilitation work. So they are overseeing it, but I'm hopeful that as I'm involved in that effort, I'll be able to bring those conversations forward, not only in questions that I have for the community about how to best answer some of the questions coming forward in the task force, but also to bring forward what's the conversations that are happening in the task force. So I'm looking forward to that. And then the last one is very preliminary, but I wanted to call it out. So I'm working with the Whatcom response team, so Melora Perry and Hannah Fisk and the state on a couple of potential regional facilities in Whatcom County, extremely early in the conversation, but one is currently a body of analysis that's being done, that's contracted from the governor's office to do an estimate on a new kind of behavioral health crisis facility that would be different than those that you guys already have in Whatcom County, would be a regional resource, and to see what it would look like to design it and to see if they could move it forward. Everything from potential police drop-offs to crisis stabilization to sobering center. They're very early in that conversation. It would then go out, the recommendation would go out, then they would work through various process to get to a final recommendation on that facility. But we are partnering with them, and I've pulled in Whatcom staff to help in those conversations as well. It would be great to get that type of crisis facility in Whatcom, but I make no promises because I don't know where the state government will go on it. And then simultaneously, there was an approach of a company that's looking at starting some residential options. And we're actually seeing if those two models might pair well together. Again, specifically to this work group, I think there's an aspect of competency restoration that's in this mix as well, that we're trying to see if this would be a new resource for competency restoration in the community. So more to come on those as I'm able to share more, but that is, these are major bodies of work currently flowing through our system.
Do you have handles for those two different models so we know kind of what you're talking about? When I say handle, I mean, is there a certain designation or something that we could refer to?
One, if I refer to it just as a residential program, that's the most I can do. The company that's approaching us all to see if there's a way to partner with us is coming out of California. It is a residential program. The conversations we're having with the state and other partners would need to happen even if it doesn't go with this company. So I hesitate to say specifically the name of the company because I don't know if they'll continue to be tied to it. But the residential program would be, from what I can understand, potentially a new designation in Washington State. So that's why I can't really say.
Is this in place of the 23-hour crisis clinic?
No, the residential program is in addition. It would be a longer term kind of residential treatment facility for people to restore competency and or come out of a hospital and have a period of time of residential stability before they go into other community placement.
Thank you.
The other one, the other facility that is being analyzed by the state right now, at its highest level, I can just call it a crisis facility. But no matter where it goes in the future, we would be looking at the continuum to figure out how it would kind of bridge in and braid in with existing programs that already exist in Whatcom County. So I don't have any better moniker or handle for that right now except a crisis facility.
Okay.
I wish I did because I think some of my conversations can get kind of confusing because I'm having very generic terms, but these are very early stages, and we'll see kind of where those conversations go.
Thank you.
For more information on our programs, I've included our general website here, as well as our supplemental provider service guide. So all of our contracts actually exist in this provider service guide. Our contract language that we do via amendment is actually very limited in language. It refers back here, and this is where programmatic requirements are actually listed. It's completely open to the public. There's no reason the public can't access it. Just know that providers in our system operate by our provider service guide. They also operate under WACs. They operate under RCWs. They operate under the Medicaid state plan. So providers have multiple levels and layers of contracting language that sits above them. And then for my own contact information, I include that as well, my phone, my email. For anyone on this call, for any reason, never hesitate to reach out. I really enjoy figuring out how our work bridges with others in the community, and also problem solving. I enjoy active problem solving. So we are public servants at the ASO, and I want to make sure that we are putting ourselves out there to work with partners in the community in any way that makes sense. And then really quick, I'm going to stop sharing this and I will share that Opioid Abatement Council slide that I promised. 1 second. Okay. I think you guys can see it's got a green slash at the bottom, right?
Yes,
Approved
we
for
can see it.
purposes. Perfect. So this is the list. Again, these are the kind of headlines in the One Washington Agreement. That One Washington Agreement is available on the state's website. I can even include this slide deck. I have no issue doing that. This is a very basic primer on the North Sound Opioid Abatement Council. But the approved purposes for settlement dollars include treating opioid use disorders, supporting people in treatment and recovery, connecting people who need help to the help that they need, connections to care, address the needs of criminal justice involved persons, address the needs of pregnant or parenting women and their families, including babies with neonatal abstinence syndrome, prevent overprescribing and ensure appropriate prescribing and dispensing of opioids, prevent misuse of opioids, prevent overdose deaths and other harms, first responders related to the opioid epidemic, leadership planning and coordination related to the opioid epidemic, training related to the opioid epidemic, and research related to the opioid epidemic. These are all very broad categories, and I can tell you, having been in behavioral health for a very long time, having seen all the sub descriptions of this to the earlier question about can these funds be used in partnership with law enforcement, absolutely. It was listed within the subcategories, and I think that that umbrella of touching opioid epidemic related issues is extremely broad in the One Washington Agreement. Any questions?
I do have a question. Let's see, we have about, I'd like to take 10 more minutes or so, and open it up for questions. I was reading the Everett Herald a couple of weeks ago, wherein there was being reported that Compass was closing a important clinic there. The executive director or CEO of Compass was saying that part of the solution would be to use community, or let's see, certified community behavioral health clinics. And my understanding is that Lake Whatcom treatment is one of these, though we're somehow Washington is not part of this kind of like model that where these are used. I'm just starting to get to understand a little bit of this. Are you do you see this model as something that we can run with and will improve the continuum of care?
Yes. So very short answer. Longer answer, CCBHCs, I was actually involved in an application for CCBHCs in King County, having written it. So I'm very familiar with the requirements and what CCBHCs are. So for a layman, the CCBHC model is a model that SAMHSA, our federal level office, is extremely supportive of. It essentially takes what we see on the medical side when you see federally qualified health centers, so FQHCs, that is your CMARs, tend to have all these types of services under one roof, right? CCBHCs at the highest level of summary are the same thing, only in behavioral health. So all your behavioral health care is under one roof. The idea is you make behavioral health care really easy to access. That's everything from outpatient to PACT to various outreach programs to ensuring that they meet requirements for service members and actually meeting those requirements as well, which are even higher bar. The CCBHC model, I will also say, my experience in our system is that people often have expressed some significant concerns about behavioral health agencies in the community. And I think behavioral health agencies are under a lot of pressures. So this is not to belay those concerns, but also to say our system is not completely holistic yet. CCBHCs from a community member standpoint put a lot of requirements on the provider to meet the community's needs and actually put really specific data requirements on them to ensure that those facilities meet the needs. From a provider's perspective, and the reason Tom Sebastian, the executive director of Compass, calls it out, in order to have that one roof model and have all the services under one place, you need a sustainable rate, right? And so CCBHCs require a payment model from the managed care organizations that's actually sustainable to agencies and allows them to pay their workforce what they need to pay their workforce to keep them. So on both sides, it can be really beneficial to the community and to the agency. It also would allow for that type of facility to be in some of our more rural communities. So I can tell you, Island and San Juan County, very difficult to serve, to get services out into that area. This provides more opportunities for that. All of the eastern sides of our 3, even I-5 corridor communities, extremely difficult to serve, to get providers out there. So this creates more opportunities for that. The issue that we're finding is SAMHSA put out 2 different types of grants. One for the state level to do the planning at the state level that needed to be done, which includes working on those rates, because that's a whole new model of rate setting than the Healthcare Authority has had to do in behavioral health. And they put out the SAMHSA grants for agencies to actually start to do those transitions themselves. As you can imagine, very costly, requires a lot of innovation to bring all those services, sometimes services an agency has never done, under one roof. Washington State did not get the grant application. They were not awarded the grant, which means they have not been focused on figuring out how to make this sustainable. Of the 17 agencies that did get the CCBHC grant from SAMHSA, what I understand from a recent conversation is that 7 of them have already had to close their CCBHC model because the rates are not in place to support them, which is really unfortunate. That CCBHC grant was $1 million a year for that agency over a 4-year period. It was the transition funds they needed. And my fear is for some of those agencies, they may never try again until the state is in a position to actually support it. And I do think that if this is a model we want to pursue in Washington State, it will likely need to be pushed through more legislative efforts. I don't think the state is moving very heavily in that direction right now.
Thank you for that overview. I really appreciate that. What other questions do we have? We have time for 1 or 2 more. I'm not seeing everybody on my screen, and no more questions? Okay.
Thank you. That was
Well,
super helpful.
it really was. What a great presentation. Thank you so much for taking your time today. I think that this will be paying off in all sorts of different ways, and I look forward to working with you in the future. So
Perfect.
thank you.
I will send the PowerPoints on to you so you can
Please
disseminate
do.
them to the rest of the group. And then, as I
Yes.
said before, reach out to me anytime. I'm happy to partner in any way that makes sense.
Fantastic. I appreciate it. Okay, we will
Thanks,
head
everyone.
on with the rest of our agenda. Thank you for joining us. All right, our next item is the annual report. Jill, would you like to take a few minutes with us?
Sure, I can do that. The draft content for the annual report is in your packets. I'm not going to go through it today. I will let you know it's draft and will be revised for proofing, consistency, style, formatting, that kind of thing. The organization of the content this year has changed. In the past, we focused on what each group was doing. This year, the steering committee has agreed that the content should be changed based on topic. So things will be organized by topic instead. The feedback that I'm looking for today really is just suggestions on that content. Is there anything missing that should be included in the annual report? anything missing from what the task force and its committees have done in the past year. If you have that feedback today, that would be great. Otherwise, feel free to review it and then submit me your feedback via email by the end of this month.
Great, thank you, Jill. Yeah, I would encourage everyone to take a look at the material that was in your packet and give specific comments. Scott, please go ahead.
Yeah, I see on page 2, it says the Whatcom County Fire Chiefs don't have confidence in, I think it's the Deacon and Deacon Center of Hope facility. I guess who's working with them and how can we get them to have confidence and why don't they have confidence?
That was a discussion, and I'd have to go back and look at my notes, Mayor. I apologize, I don't have it at the top of my head. That was a discussion that occurred when there was a review, and I can't remember if it was in the full task force or if it was in the joint committee meeting back in March, I believe. And I
think it
wanted
was
to
the
reach out to
joint
Mike
committee meeting.
Hilly. He might have been talking about that. I don't know that Mike is with us today, but I can ask him to provide some clarification on that if you like.
Scott, it came up in our joint meeting of the Behavioral Health and Law and Justice Committee, I believe. And it would be, I'd be happy to talk with you about that, and or you can review the tape. But there's a good conversation going on there.
Okay.
And Mike would be an excellent person to talk to.
All right. And then on page 5, I see the cities participate in the program, but Ferndale and Nooksack aren't listed. Do they have in the court programs? Do they have separate programs, or is Nooksack associated with Everson and Ferndale has something separate? I guess I was wondering why all the cities aren't listed in that first paragraph under court programs.
The court program presentation was given by Bruce and Jake. So I would ask, let's see, I think they were both here. Jake is here. Yeah, and Bruce, maybe to clarify what services they provide for the small cities.
Yeah, I could jump in there real quick. We provide services for us, probation services for Blaine, Everson, Sumas, Linden, and the city of Bellingham. So we do not provide services for Ferndale, as they have their own probation officer in-house there.
Okay, all right. That I think covers my questions for now. I'll send a copy of my questions to whoever sent this to me, and I'll have a more comments.
Send them to Jill.
Yeah, we'll do. Thanks.
Thank you, Scott. Raylene.
Thanks. Just to follow up on Scott's questions, Scott, Everson and Nooksack are combined, so that covers that one. And on your earlier question, it was discussed on when people are being dropped off, law enforcement is restricted on some means of drop-offs, and as well as fire. If somebody's combative, there's certain rules and requirements that were concerns at the Deacon Center for Hope. Those were addressed, and I think Mike Hilly and Perry were working with law enforcement on that. And I think that's why they were looking at the 24 or 23 and 59 minutes service center to address some of those other concerns and licensing. So those are stuff that are being worked on. But law enforcement and medics were, some people they can't just bring to the Deacon Center home because of licensing issues, which means they're going back to the hospital. So I think Perry had more information on that, but I think the videos kind of speak for themselves on that. So thanks.
Perry, go ahead.
Thank you. Yes, accurate. Thank you, Raylene. One of the challenges that we run into is the licensure and certification for our Deacon Center for Hope is that it is a voluntary facility. And what that essentially means, the staff cannot go hands-on with an individual, with a client. And at times, law enforcement, and others can be a little frustrated or struggle with that to a certain extent relative to unsure about where they're to take an individual. But we do work really closely with EMS and fire. We also have a monthly meeting with the providers as well as fire, EMS, etc., to address issues as they come up and challenges and needs. So those are a couple of the ways that we're addressing that at this point. I haven't reviewed what Jill sent out, just came back off vacation, but I will also review that and take a look at the meeting as well in our preparation.
Thank you, Perry. Thank you, Raylene. Perry, I just wanted to let you know that section is a little bit different from what you submitted at the steering committee, which I think you were on vacation at that time. The steering committee did ask me specifically to get a little more in depth in that section about some of the concerns that were expressed during that meeting. So yeah, you might want to take a look at it. I will also run this section past Mike Hilly specifically to make sure that everything reflected is current and correct. So thank you for that feedback, everyone.
On my screen, I see a strange hand up on Birdie's picture. Is that a raised hand or something else? Okay. All right. Okay. Any other things for Jill regarding the annual report? Please do review and get your comments in. That'd be great. And we will close that and move on to our next item, which is the proposed IPRTF committee reconfigurations and focus. I'm hoping you all reviewed this document. We are going through us co-chairs and Bertie as well. We're attending all meetings over the last, all the subcommittee meetings, and encouraging each of the committees to consider their charters, consider what has been working, what has not, to improve process. We're taking a couple months here to listen carefully to everyone who is involved in IPRTF and its committees. And this document was an attempt to look forward to the next 12 months at least, and distributing the projects of the implementation plan to help focus the committee's work. And so I'm here to take any comments, or if you have not read this yet, especially if you're a committee chair or on one of the committees, if you could take a look and give us comments and feedback and consider how we move things forward in the IPR towards action. And I'll take any comments or thoughts from anybody. Okay, not seeing any comments. If you have not reviewed the document, please do. And let's move our committee work forward at pace. Okay, the next item, I believe, is the Justice Project Implementation Plan update from Barry.
Yeah, good morning, everybody. How's it going? We don't have much to report out. As you know, we've been tracking this RFP for our facilitator, and we have that opening was last week, that bid opening, and we are now in the evaluation stage of the proposals we've gotten. I think that'll take place this week. We came to a conclusion, at least I did. I thought it was a good idea to have the entire planning team be involved in the review of those proposals rather than just a couple of us. So I think you can look forward to that decision probably in the next week or so. Jill, do you want to add anything? I don't want to get ahead of you.
No, I think that sounds about right. I would ask those planning team members who have not submitted their evaluation to please do so in the next day or two. And then we'll need to decide if the planning team wants to interview the two applicants.
So that's basically from my end of the implementation plan where we're at. Any questions? Any questions on that effort for that RFP? Okay, thanks.
Okay, thank you. All right, we'll move on to committee updates. We can take 5 minutes per committee. I'd like to, instead of repeating what is already in the notes, which everybody is responsible for reading, if the committee co-chairs might want to really focus on something of great import or interest that has come up in the last month. In particular, let's give 3 to 5 minutes for each one, and let's begin with Crisis Stabilization Facility Committee. Perry?
Yes, good morning, folks. Perry Mowry. I'm a supervisor with the Response Systems Division, and I just came back off of 2 weeks of vacation, so I'm ill prepared here. I'm ashamed to admit, but a couple of the things that I think really are worth standing out. My manager, Melora Christensen, and I have been meeting specifically and directly with the two providers, Pioneer Human Services Detox and Compass Health Mental Health Stabilization at the Ann Deacon Center for Hope. And looking at a number of very specific projects and steps that we can take to support the providers in further addressing challenges to providing services, as well as continuing education, some of those kinds of pieces. We'd really like to open the lobby, which presents some challenges just relative to security and some other pieces. But that's one example amongst others. Some of the things that we're focused on right now to make the facility more usable. Again, address some of the pieces that have come up in regard to fire and EMS, law enforcement, et cetera. To that end, we have made arrangements for, I don't know how familiar people are, but the Dijwalik Wellness Center in Anacortes, really an extraordinary program. If you haven't talked with them or maybe been a part of that program, truly very extraordinary, and particularly the orientation towards harm reduction, as well as the person-centered care that they offer. Having been involved with them in some projects and so forth, I asked if they would be kind enough to facilitate a tour for each of our providers, Pioneer and Compass Health, individually, and then talk with them about how the Dijwalik Wellness Center supports and facilitates person-centered harm reduction orientation in their facility, and how they do that from an administrative standpoint, because truly it really stood out for me when I completed the tour and so forth. So we've made those arrangements for both Pioneer Human Services and Compass Health to attend. They willingly accepted that, as well as additional training. And this has really come up out of, I think that folks are aware that we use a systems improvement form that's an online form that can be completed by our first responders and other entities, within the community, obviously. And so we really target, as those systems improvement forms come in, where there is a challenge of what is a specific action step that we can take in order to address this, as opposed to addressing simply the individual incident that occurred. Is there a larger systems challenge? And that's really been beneficial in my opinion. So that's what we've been focused on predominantly for the last month. Thanks for your time.
Perry and everybody, in the proposed IPRTF committee reconfigurations and focus, that committee that Perry was just referring to, and it's been proposed that that we reconstituted into being more of a facilities committee in general, focusing not just on the Ann Deacon Center, but 23-hour center, which is in planning right now, and other facilities. And I'd look for any of you to think that through, to look at the document that we're referring to here, and give it some time and thought. Okay, Behavioral Health Committee, who's going to be speaking on that? Mike? Or
I think I'll go
Dan?
ahead and start it, and then
All
I
right.
have Co-Chair Dan Hamill chime in here. So thanks for the time. Thanks for the other updates. So the Behavioral Health Subcommittee recent meeting, we were talking a lot, Peter. This is actually kind of an aligned goal that you and Heather and Bertie have been talking to groups about, which is how to become more action oriented. The group kind of went through some of our past work. The Behavioral Health Subcommittee in this task force has been quite active over time. And so committee members went over kind of some successes and wins, but we really got down to kind of a process end. And we talked quite a bit about process, what processes make us most effective. In addition to looking at our processes, and some of those things, by the way, involve kind of having formal outputs. Maybe that would be a recommendation or something that we lift up to the steering committee. So that was one tangible aspect, and then being able to track those in future meetings. The group also spent quite a few minutes actually going over what are the current issues now, what's bubbling up for members now. We have a broad, diverse representation from various different programs, from county programs and other provider programs. So we spent some time talking about what are those most important things that the Behavioral Health Committee thinks would be either needed or would fit into our SIM. So we started that process, and we look forward to continuing that with a ranking exercise. So we're going to go back to Behavioral Health Subcommittee members with kind of, hey, this is what you said, but what are the priorities? What's a good order of doing things? So yeah, very, very kind of deep dive into process. And then I would just add that we also discussed how an application of racial equity toolkits, and how does that inform the process? How does it drive the process? And in what ways, kind of did a quick litmus test, in what ways are we meeting the goals of that? And in which ways do we need to grow? And with that, I will turn it over to my co-chair, Councilmember Dan Hamill.
Thanks, Mike. Good morning, everyone. Just wanted to add a little bit to Mike's comments. We are trying to round out the roster, the membership of the Behavioral Health Committee to kind of get back to where we were about a year and a half ago. We did lose some members due to job transitions and such. Do want to make an announcement here this morning. Just got Mike's permission to say this, but Mike will be transitioning out of the co-chair role at some point here this year. And I talked with Stephen Gockley about coming in as a co-chair, and he agreed to do that. So that's in process. Dr. Wu has joined the Behavioral Health Committee as a member, and we've got some other folks that are kind of waiting in the wings to come on board. The whole idea is to diversify the membership of the committee and to broaden the work that we're doing. I would add that I've been working along with Perry and Melora kind of in a separate capacity with the Digwali clinic to get mobile medical units up to Bellingham to provide opiate treatment services, Suboxone and methadone in particular. And that process is getting close to being complete. And on the city side, I speak as a co-chair, here for the Behavioral Health Committee, but I also speak as a city council person. And we are looking forward to the development of the Division Street property into a behavioral health campus. And I know that it's going to be a lot of work with the county, and the county's likely to lead that effort. But a lot of folks from Bellingham are going to be receiving services there. So we're heavily invested in that process. So I wanted to put that out there to the group here today. that we look forward to being an active participant in that, in what that's going to look like. Mike, any other further items?
I think you captured it really well, Dan. Thank you. And it's been an honor to co-chair with you.
Likewise. And yeah, I mean, we've been doing this for a while now, and we'll have to do some kind of like celebratory, like have a coffee or something or whatever. So anyway, I'll turn it back to you, Peter.
All right, thank you so much. That reminds me that in the proposed IPRTF committee reconfigurations and focus document, there is a plea for each of the committees to round out their committees, really take a look at their roster, encourage a diverse group of folks from our community who can fully participate and make a difference in these committees. So it would be great for each of the chairs and the committees to really focus on the constitution of their committees. And, these things can kind of get off your radar over time. Let's fill those seats and make sure we have all the voices in the room that we need. Okay, on to the next one. We have Index Committee. Bertie? You're muted.
Now
Okay.
I'm unmuted, yep. So the Index Committee is also in the process of re-looking at its original work plans and what we can do to gear up to become more active this year to provide information to guide the IPRTF and its work. And in doing that, we have agreed to form 2 work groups that were originally part of the Index Committee plans. So what I would highlight today is that we are actively looking for people who are interested in being on these 2 work groups. The one work group we are calling the policy work group, and its role is to prioritize our data requests so that we have an orderly set of requests to the IT folks. And the second work group is actually the IT folks whose representatives who will be in the trenches doing the work. We look forward to the new system analysts that will be hired by the county to inform us, and we look forward to joining our work with the health department in ways that we can utilize each other's strengths and do this all in a coordinated fashion. I think the questions that we want to consistently put out is, for everything that we do on the IPRTF, is what is our goal? What are we trying to accomplish? And what information do we need to track and know if we're actually accomplishing it? So I encourage you, as each of you on your committees, as you think about your work, to kind of run that question by and let us know what information is most helpful. How will we define success? So having said that, we are very much interested in people who would like to volunteer and express their interest for the 2 work groups. So if any of you are, I would encourage you to reach out to me, and you can do so through Jill if you don't have my contact information. But we look forward to getting those work groups on the ground. They will meet monthly, and the Index Committee meets every other month. Any questions or comments?
That's great. Any questions or comments for Bertie and the Index Committee? Well, Bertie, I know this weekend I was doing some work and was listening to a podcast, and I took a couple notes on metrics that I would really like to see for policymakers and for us to determine what's working and what's not as far as incarceration prevention and reduction in Whatcom County. So I'll get those to you.
Excellent, thank you. And the other thing I should mention is I think there's consensus that it's very important to be respectful of our GARE participation and to make sure that we are collecting in a uniform way race, ethnicity, and language distinctions self-identified across those individuals that we are measuring. So that may be a bit of a challenge for our current systems, but I think we agree that that's a large priority.
Very good. Yes, absolutely. Okay. Raylene, are you speaking on behalf of the Legal and Justice Committee?
Yes, thank you, Peter. So we discussed at the last Legal and Justice Subcommittee the current standards for indigent defense and the new standards as adopted by the Washington State Bar Association's Board of Governors. Those are currently with the Supreme Court. They have not started taking comment on that. But the impacts, if they do, and if we are required to adhere to those conditions, which haven't been put in place yet, could have a drastic effect on the criminal justice system here in Whatcom County and as the state as a whole. So currently, just to give you kind of a brief overlook, the current standards tap a public defender caseload at 150 felonies or 400 misdemeanors per year. Nationally, statewide, there is already a shortage of public defense attorneys. And so if these are put into place where the court has to adhere to this, it will mean that we need a lot more public defenders and the cost is high. And there's definitely some good things about the standards that are coming out, but how is this going to look and how is it going to impact the criminal justice system and incarceration individuals that are represented, or how many people will be unrepresented because we don't have enough attorneys or we can't afford to pay them, are all concerns that we are watching and waiting for to see what the Supreme Court has. There's a lot more information on this in your packet, as well as the hearing was, or the last committee meeting was recorded. So if you have more questions on that, myself or Maya and Eric Ritchie might be able to assist in getting you that information. Also looking for a co-chair for the Legal and Justice Subcommittee and implementing the new reconfiguration to the Legal and Justice Subcommittee. Thank you.
Thanks, Raylene. Any questions for her? Okay, last item there is steering committee, and Barry, you're the chair of that.
Yeah, hey, everybody. Steering committee, as you know, is responsible for, kind of putting things on the agenda. So we usually run out of things to talk about by the end of our agenda. But we do have a couple of points that I think that the steering committee is working on that are important and worth mentioning today. And that is the recruitment and the succession planning effort that we're trying to get off the ground with more communication and more emphasis on our GARE responsibilities, which is the government accountability for racial equity. We have the GARE toolkit, and we're looking for more BIPOC members of the task force and in leadership roles. So I think that's a big emphasis. How do we plug in the Whatcom Racial Equity Commission to the task force? I think that's an important question that we need to figure out in steering. That's really going to be critical to us being able to really engage in a lot of our goals around the GARE toolkit. So those are really the only things I have today that are kind of outside the norm. Any questions?
Okay.
Dan?
Yeah, I want to go back to your point about how to engage the Racial Equity Commission. I think that we do need to do that, and we really need to have a really frank conversation as to how that's going to play out. I just think that we adopted the GARE like way ahead of I don't know. I think that we were an early adopter of that, but I don't think that we really implemented that very well. And so I'd like to make sure that when we engage the Racial Equity Commission, that we do so very thoughtfully And I mean, the things that we're doing here are absolutely impact BIPOC members of our community and many other folks. How can we make sure that we do it the best way? And so I want to make sure that we have a really good conversation, whether it's in this room or in steering or what have you, but let's do it the right way.
Yeah.
It does seem like this might be a good subject for an upcoming meeting of this body to review the GARE 6-point items and a talk in steering about how to integrate into our process better than we have done in the past.
So the council has appointed the members to the Whatcom Racial Equity Commission. We did that a couple meetings ago, so we're looking forward to that getting seated and getting their work off the ground.
Okay. All right. Unless there's any other questions for Barry, we'll move on to other business. Call for other business, anybody? Okay, hearing none. Jill, do we have members of the public who might be wanting to speak?
We do have a number of attendees with the task force today. If any of you would like to speak to the task force, please virtually raise your hand now. And no hands are raised. Peter, do you have anyone in the conference room with you?
I'm sorry, Jill, I didn't hear that. What was that?
Do you have anyone in the conference room with you?
No, I'm all here all by myself. Very lonely. Okay, well, with that, I'm going to close the IPRTF meeting for May 13th, 2024, and give you back 25 minutes. You're all so busy doing great work in our community. I really appreciate whether you are a staff member, volunteer, whomever, thank you for doing the work that you're doing, and let's use those 25 minutes. So thanks a lot, everybody.
Heather and Kayla, if you have a second to stay behind, I just have a quick question for you both.
Absolutely.
Thank you.